Let's jump right into thoracic trauma and post-operative pulmonary care for Step 2 CK. We are going to apply strict next best step decision logic to mechanical injuries, chest tube output thresholds, and pulmonary complication escalation pathways. When you're looking at any blunt chest trauma, your very first move is to decide, is the patient hemodynamically stable or unstable? Unstable trauma patients need immediate resuscitation, an EFAST exam, a chest X-ray, an ECG, and immediate stabilizing interventions, like getting a chest tube in right away if indicated. Now, if you can't achieve or maintain that stability, you have to move straight toward operative management, specifically an OR thoracotomy. On the flip side, if the patient is stable but had a high-risk mechanism of injury, or if their initial exam, X-ray, or ECG is abnormal, then you can safely proceed with additional imaging, like a CT of the chest. Okay, let's talk about uncomplicated rib fractures in stable patients. The absolute essential management here is pain control. Why? Because pain causes shallow breathing and a poor, weak cough. That splinting behavior directly leads to retained secretions, atelectasis, and eventually pneumonia. By prioritizing adequate analgesia, you're actually maintaining the patient's ability to take deep breaths, use incentive spirometry, mobilize early, and produce an adequate cough. You also need to use the specific location of a rib fracture to predict associated injuries. If you see fractures in the upper ribs, so ribs 1 through 3, you need to suspect damage to the subclavian vessels, the brachial plexus, or mediastinal vessels. Moving down to the lower ribs, 9 through 12, the threat shifts to intra-abdominal organs. That means the liver on the right, the spleen on the left, and the kidneys posteriorly. And keep in mind, a fracture at literally any level can be associated with an underlying pulmonary injury. Next up is flail chest. The mechanism here involves extreme blunt force fracturing at least 3 contiguous ribs in 2 or more places. This creates a completely free-floating chest wall segment. During inspiration, the negative intrathoracic pressure actually pulls this detached segment inward, which causes that classic paradoxical chest wall motion. These patients will present with severe chest pain, tachypnea, and rapid, shallow breathing. You'll treat this with heavy analgesia and supplemental oxygen, but remember, if they hit respiratory failure, they require positive pressure ventilation. Now, the sheer blunt force required to cause something like a flail chest frequently injures the underlying lung, and that results in a pulmonary contusion showing up within 24 hours. The alveolar hemorrhage and edema severely impair oxygen diffusion, so you'll see tachypnea, tachycardia, hypoxemia, and rales with decreased breath sounds. A CT scan is going to be your most sensitive imaging choice here, and it will show irregular, patchy alveolar infiltrates that are not restricted by anatomical borders. Management comes down to pain control, pulmonary hygiene, supplemental oxygen, and ventilatory support if they need it. Let's contrast a hemothorax with a pneumothorax, since both feature decreased breath sounds on the affected side. A hemothorax gives you dullness to percussion because blood is literally filling the pleural space, often from torn intercostal vessels. And since one single hemothorax can hold a massive volume of blood, these patients frequently show up in hypovolemic shock. A pneumothorax, on the other hand, fills that space with air. So instead of dullness, you get hyperresonance to percussion, and if it becomes a tension pneumothorax, you'll see a mediastinal shift. For a hemothorax, you have to drain the blood to prevent a trapped lung or a later emphysema. Your initial next best step is chest tube insertion, alongside fluid resuscitation. But you need to know exactly when to escalate to an immediate OR thoracotomy. The strict thresholds for the OR are an initial chest tube output of more than 1,500 milliliters, ongoing bleeding of more than 200 milliliters per hour for over 2 hours, or a continuous need for blood transfusions just to keep the patient hemodynamically stable. So what happens if you place that chest tube, but you see a persistent pneumothorax and a significant continuous air leak? That specific scenario strongly suggests a tracheobronchial rupture. Other clinical clues include dyspnea, hoarseness, bloody tracheal secretions, subcutaneous emphysema, and pneumomediastinum. That pneumomediastinum can actually produce a crunching sound over the heart, which is known as Hammond's sign. This injury can definitely mimic a tension pneumothorax, but it usually lacks that classic midline shift and the distended neck veins. When you suspect a tracheobronchial injury based on those clues, the definitive diagnostic test is bronchoscopy, so you can directly visualize the tear. And for definitive treatment, that requires surgical repair. Shifting gears to postoperative care, atelectasis typically hits about 2 to 5 days after surgery. It results from a combination of splinting from pain, a reduced cough, anesthesia, immobility, and retained secretions. How you treat it depends entirely on the secretion volume. If secretions are minimal, you use CPAP to force open those collapsed alveoli. But if you're dealing with copious, heavy secretions, you need to use chest physiotherapy and targeted suctioning. If ventilation still remains inadequate after that, you escalate straight to BiPAP or invasive positive pressure ventilation. Of course, the best strategy is preventing post-operative atelectasis and pneumonia from happening in the first place. You do this with early aggressive pulmonary hygiene. We're talking early mobilization, deep breathing exercises, and incentive spirometry. And again, adequate analgesia is foundational here. Without it, the sharp pain from a surgical incision prevents the patient from taking the deep breaths they absolutely need to keep those lower airways open. Finally, let's look at preoperative testing. For high-risk upper abdominal or intrathoracic surgeries, specific baseline tests are required. You need a preoperative chest radiograph for these high-risk surgical locations, or if the patient has any history of cardiopulmonary disease. Additionally, an ECG is indicated for patients with a known history of coronary artery disease, arrhythmias, or even asymptomatic patients who are simply at a high risk for major adverse cardiovascular events.